Good morning, Chicago. I'm Dr. Allison Arwady, Commissioner at the Chicago Department of Public Health. Today is March 21st, 2023, and as always, thank you for joining us. This is your opportunity to get your public health questions answered live. You can use the hashtag AskDrArwady on Facebook or Twitter, or put your questions directly into the box below. So pleased to have a guest today. This is somebody who has been on Facebook, a number of times over these last few years. Matt Richards is our Deputy Commissioner for Behavioral Health at the Health Department, meaning he and his team work on mental health issues, substance use issues, and violence prevention and intervention issues. So you guys have been very busy always, but especially, during COVID and growth of systems level work over these last few years. So do you mind just so folks kind of have a sense of
Sure.
who you are
Yeah.
and they can start putting questions in for him, for me, and then we'll move into some content.
Yeah, I'm a licensed clinical social worker by training, so my background is in mental health and addiction treatment, and as Dr. Arwady said, that's a big part of my focus, but I also work on a lot of public health and safety projects, integrating mental health professionals into the 911 system, programs that divert people who have mental health and substance use issues into the community and away from the court system. You forgot healthcare for the homeless, which is the other.
I didn't forget it.
Which is the other area that I work on. But pleased to be with you. There's a lot going on and excited to talk about it.
Yeah, perfect. And it continues to be the area that we are getting the most questions about. I think there's a lot of interest in behavioral health in Chicago, which I think is great. And so appreciate you coming back.
My pleasure.
We've had different folks from this bureau talking about different sections, but there's a lot going on and new things happening almost every month out of that program. So let's go ahead and dive in. As always, we'll start with our data on COVID, and I'll do a quick where are we on COVID and infectious diseases. Then Matt will do just a brief overall of some of the newer things happening in behavioral health, and then we'll use the second half of the time to take your questions live. So let's start with the dashboard, chi.gov/COVID-. And first of all, I just want to highlight that everything continues to look good from a COVID perspective. We are not done with COVID, but things remain in good control. We're averaging about 270 lab-confirmed cases every single day in Chicago. That's in addition to the hundreds or thousands of people still being diagnosed daily through at-home tests. We still have 24 Chicagoans on average being newly hospitalized with COVID every day. So again, not over. These folks are more likely to be older, to have underlying conditions. It's especially important for people who are older or have underlying conditions to stay up to date with vaccines and to take early treatment if you do get diagnosed with COVID. We are averaging less than one death a day, but we are up to 8,092 cumulative deaths from COVID here in Chicago, and that continues to grow every day. We're still doing almost 800 COVID vaccinations every day in Chicago. This tends to be the number that surprises people. I think there's a lot of folks out there who think, nobody's still getting vaccinated. Well, almost 800 a day, 7 days a week still are. And that's been getting people, especially the updated booster against Omicron. Less than 2% of our emergency room visits and less than 3% of our hospital beds across the system are taken up with COVID. So everything is looking good from a COVID perspective as we're in the 3-year anniversary of when the whole world started paying attention to that. I'm going to just turn now to a little bit, some other pieces here. So first of all, we are still at a low COVID community level. A reminder that we calculate this every week for both the city of Chicago and for larger Cook County. And this is done nationally. It looks at the number of new lab confirmed cases, the number of new hospital admissions, and the percent of our beds taken up by COVID patients. And all of these remain at that low level. And the one we're watching the most closely still are the hospital admissions. New admissions per 100,000 population in the last 7 days. We need that number to stay less than 10 for us to stay at a low level. And you can see across Cook County, it's at 7.1, which is pretty good, but the one that we're continuing to watch. The country overall also doing very well as we're heading into spring, coming out of what has traditionally been the respiratory virus season. Just 1% of U.S. counties reported a high COVID community level in orange. orange, just one county in Illinois, and 9% across the country reported a medium level. And you can see a few of those counties in downstate Illinois. That's especially in areas where we see more healthcare strain. That tends to be what pushes counties into that medium or even high level. And I'm very pleased to be in green and hopeful that we stay there. Just to get in a little more detail, the health department continues to update this data every week. This is what lab-confirmed COVID cases look like in the city of Chicago. Darker areas on the left are the areas where we are seeing more lab-confirmed cases, generally meaning people who are seeking health care for their symptoms. And then on the right, this just marks if we're seeing significant change. Areas in green, we've seen a decrease in cases in the 2 weeks prior to the 2 weeks before. Areas in red, a little bit of an increase. But overall, both cases and change are relatively low. We're not seeing huge patterns of changes in spread, which is good. Also, our COVID hospitalization rates remain low overall. Again, darker blue on the left means higher rates. And so consistent with what we've been seeing largely throughout COVID, we still are seeing higher rates of COVID hospitalization in people who live on the west side, the near south, and the far south regions. And then on the right, again, red is where we're seeing some increases. Green is where we're seeing some decreases. So again, no major changes here, but COVID continues to land differently in different parts of the city. And we continue to be really focused on making sure that people in the parts of the city where we're seeing more hospitalizations, more serious illness, are up to date with vaccines, are able to access treatment. Our lab-based early alert COVID signals, which again, the health department has invested a lot in. We update this data every week. You can download it from the data portal. First of all, in terms of variants, we're at a medium risk, and that has to do with whether we're seeing any variants that are increasing in prevalence. I'll show it in a second, but this XBB 1.5 is what is currently the one that we're keeping an eye on, but nothing hugely concerning. And then our wastewater score is down to low. And that's where we were last week, medium for variants and low for wastewater. Happy with that. But these are some of the metrics that let us be prepared in case we were to see, an unexpected new variant, a change locally, a part of the city showing up that isn't dependent on individual testing. Just to go a little deeper on variants, because boy, those of you who watch COVID Live pay a lot of attention to variants, and it's still what we get a lot of questions about. Everything is still Omicron. That is the most important thing if you're somebody who worries about variants. It is fantastic news that for now, more than 15 months, every subvariant that we have seen, XBB.1.5, BQ.1.1, all of these are all Omicron. And as long as we don't have another new named variant of concern, another new letter of the alphabet, that means that we have generally good population level immunity. It means that the vaccine that came out last fall that was made specifically to help protect people better against Omicron continues to have good protection. And so the top line message on this always is it's all still Omicron, and that's good news. The subvariant of Omicron, XBB.1.5, that's in purple there. Just as a reminder, as you move to the right, that's here in the Midwest and in Chicago. Almost everything is now that dark purple, and that is what we've expected. We've been talking about this week after week, and now more than 90% are that subvariant, and we're not seeing major increases in hospitalization as a result. Similarly, across the country, almost everything is that same XBB.1.5, all still Omicron. We got some questions in about subvariants and international. I know some of you are paying a lot of attention to this, and so are we. Just so you know, some of the two subvariants that we're keeping an eye on internationally, there's XBB.1.9. Again, that's just another flavor of Omicron. We're watching it especially in the UK. They are seeing some slow uptick across metrics there, including hospitalizations, but in the US, partly because of, I think, some of the other subvariants we've seen, it's got a little bit of a growth advantage, meaning it's outcompeting a little bit, but a 35% growth advantage means it's not a variant that's likely to wreak havoc. That compares to a 500% growth advantage with original Omicron. When we start seeing growth advantages in the 500% range, that's going to be something that's a big deal. So no major concern at this time, but of course we're watching it. And then we did get a question about XBB 1.16. Yes, Yes, we are watching that one in India. In India, some parts of the country have seen, again, some pretty significant growth advantage of about 250%, real increase in deaths. Some of that, the international epidemiologists believe, is related to some changing testing patterns, but also the celebration of Holi. It's a festival that brings a lot of people together that can create spaces for spread. So no major concern for this one at this time, but we will watch as it likely emerges in some other areas. And again, I'm going into some detail here just so you have a sense of what the team at the health department is doing behind the scenes to make sure we are monitoring closely anything that may be changing. On the wastewater side, again, a lot of you send a lot of questions about wastewater. Every week, we calculate a metric for Chicago overall. Remember that wastewater is a way that we can monitor everybody without having to count on individual testing behaviors. We're able to take samples out of water treatment plants and out of sewer sheds to understand overall what are the levels of a given disease in a geographic area. Or if we're doing it at O'Hare, are we seeing new variants emerge? If we're doing it in Cook County Jail, are we seeing SARS-CoV-2 or COVID emerge in a section of the jail where we shouldn't be seeing any? Can we then bring testing in? So there's been a lot of work in this space, but happy to say that for the last 2 weeks now, we have been at a low concern level in Chicago overall, and that is better than we were throughout much of this winter. So for some details on that, we look at both on the left side here, the wastewater treatment plants. There's a big one for the north side and suburban Cook to the north. There's a middle one, and then there's a southern one. And the southern and the northern are both showing up at a low level, medium level at the Stickney plant in the middle, but nothing, again, hugely concerning. And then the sewer shed, we've got 4 sewer shed sites actually on the north side that are showing some higher levels that goes along with some of the increased case rates we may be seeing, but nothing that's showing up again at that high population level. And overall things, again, are at a low risk for Chicago. And then for influenza, just for some comparison, we actually had a non-detect for influenza on the north this last week, which means there may still be some individuals with influenza who are shedding in their stool, but the numbers are very low enough that they don't show up, and that really gives us a sign that influenza is very much on the wane. And then in both of the other treatment plant areas on the left and in every sewer shed, we're detecting a low influenza A and B concern, and that is really consistent with what we're seeing on the clinical side. So that's been good. I wanted to just highlight for a minute here just an interesting national graph that came out from the CDC, the National Center for Health Statistics. And bear with me while we look at this graph, because we get a lot of questions about, isn't COVID just like the flu now? And how do we think about this going forward? So on this graph, this takes us from 2018 all the way to the present, moving from left to right. And this gray double line that says epidemic threshold, that basically is a combination of people across this country who present with pneumonia, influenza, or COVID. And the reason it goes up and down is usually we see a seasonal pattern with that, where we see more people showing up with pneumonia, influenza, and COVID, and then frankly dying in the winter than we do in the summer. But what's been interesting is this purple here is COVID. So if you look at the deaths, purple here shows across the US how many deaths on a death certificate are coded as being related to COVID-19. And you get a sense of just how many this is. The higher this is, the more percentage of deaths and the higher number of deaths have been due to pneumonia, influenza, and COVID. And just to put this in some perspective, these little yellow bars on the bottom here, those are influenza deaths over these last, prior to COVID on the left. During COVID, we saw very few influenza deaths because COVID was sort of outcompeting influenza. And then in this most recent season here, you see that little yellow hump on the right, we've gone back to seeing some flu deaths, but even now, during this respiratory season, we have had more than 64,000 Americans die from COVID in purple, much higher than flu deaths in this season and in any pre-pandemic flu season. And so my sense is we're going to be adjusting this double gray line of what do we consider an epidemic threshold. It's going to be adjusting up because the red line, those are excess deaths, and we're still seeing more than we're anticipated. So Again, I just have a minute to kind of highlight this for you. We've got more information online about this, but want you to understand that COVID is still hitting us hard, for sure, and it has changed how we think about respiratory viruses long term. Finally, just in terms of things to do, a reminder that staying up to date with your vaccines is critical, but also anybody at high risk for severe illness. I consider that to be anybody over 50 or anybody with underlying conditions. If you test positive, there are treatments available, and you've got to take them early. Paxlovid is the best known one. It's an oral medication. Your doctor can prescribe it. Your pharmacist, in many cases, can prescribe it. And we want to think about belt and suspenders. Belt, stay up to date with your COVID vaccine. Suspenders, if you do get COVID, please take advantage of early treatment. And there's more information online if you're not sure how to go about doing that. And then finally, we continue to operate our at-home program here in Chicago for vaccination. Anybody in the city of Chicago of any age 6 months and up, we will bring COVID and flu vaccines to your home. Everybody doesn't have to live at the same address. You can get together your church group. You can get together your neighbors. You can get together your extended family. We can vaccinate up to 10 people. And we, at this point, are running Saturdays, Sundays, and Mondays, just based on demand and where people have found this the most helpful. And you can give us a call or register online. And we were looking at the data on this, by the way, and we are seeing this be the most popular on the south side and the west side. And given that that's the area where COVID is still landing the hardest, we are committed to keeping this program going. A quick note on vaccine updates. So we've been getting some questions about, do I need to get another booster, et cetera. For the great majority of the population, if you had your COVID booster after Labor Day of this last year, you are up to date. There is no recommendation at this point that anybody get an additional vaccine, except for the youngest kids. For kids under 5 who had their initial 3-dose primary series of Pfizer more than 2 months ago, they actually are now eligible to get a single booster dose of that bivalent Omicron vaccine. So if you've got questions, again, more information on the website. I would encourage you to go to vaccines.gov to see where there's availability and potentially even call ahead just to make sure that the pharmacy has it, or that even better, your pediatrician or your primary care doctor has it. But I know for a lot of you, if you were early adopters, you got your kids vaccinated as soon as you could. And we've gotten questions about when can I get that bivalent booster. That has now been authorized. Here's how we are doing with the bivalent boosters. That's the Omicron specific version that became available last Labor Day. Done more than 588,000 booster doses. We're ahead of the national average in every area except those over 65, where we are still at only 41% of Chicagoans over 65 have had that updated booster. It is not too late. I strongly encourage all ages, but especially anybody over 65, to get that vaccine. I just don't want you to get in the hospital. I don't want you to die. And that is the group that we continue to see at highest risk. So this is the data point of most concern to me still here in Chicago. And then finally, norovirus. Norovirus, not related to COVID in any way, totally different virus, but very contagious. It causes vomiting, diarrhea, and stomach cramps. It is not spread through the air. It is spread through people not washing their hands, basically. And it is very much on the rise. We expect that it may peak nationally in March. Wash your hands, wash your hands, wash your hands. You don't want to get norovirus, even though it is usually a pretty quick course of illness. It's very unpleasant. And just as a reminder, you can call 211 or we continue to operate 7 days a week, our COVID hotline, 312-746-4835 if you need any help with COVID. And with that, I'm going to hand over to Matt Richards. If you join late, he's our Deputy Commissioner for Behavioral Health. He's got some slides, just very high level where we are on some of the initiatives, and then we'll turn to conversation and your questions.
So, I first wanted to talk about our All 77 campaign. So we made an announcement about this in February, that we're now funding mental health services in every single one of Chicago's 77 community areas. So you'll notice the difference from 2019 to 2023. we're really, really proud of this. We were funding a small number of clinics and in a small number of community areas, serving a small number of people in 2019, and have seen a really significant expansion over the last 4 years. You can get connected to any of these clinics, which are no barrier, meaning we don't turn anyone away because of health insurance, immigration status, or ability to pay, by calling 211 or going to mentalhealth.chicago.gov, which I'll talk about in a second. The clinics are operated either directly by government, meaning city or county. The state doesn't operate direct outpatient clinics, or community health centers and community mental health centers, or community-based organizations that our partners operate around the city. And I listed all of these on this slide. So these are all no barrier settings. We don't fund, for instance, private practices or things like that only take commercial insurance or out-of-pocket pay. So if you go back to 2019, this is why we've been so busy over the last 4 years. We were serving just over 3,600 people a year, 6 clinics in 11 neighborhoods. You see those locations around the city. So when I started with the city in 2019, this is the map that I was working with, and we had a need to significantly scale up. So this is what where we are right now. Is last year we served almost 74,000 people, almost 14,000 children. We did not serve any children in 2019, actually. All community areas and 177 clinical sites
and so
around
that
the
means
city.
177 places where someone can get
That's right.
mental health care free,
No barrier.
available, no barrier.
Correct. So again, we don't list sites on here where, for instance, you would have to have a particular type of commercial insurance, or where you would have to pay out of pocket. It has to be a sliding scale down to 0 or free. This shows all the providers that comprise the network. So this is really how we've gotten there, is by expanding our own city-run services and then making investments in providers all around the city. Part of it has been becoming a much more serious funder of mental health services. Our mental health budget was $12 million in 2019, and this year it's $89 million. So the first thing we needed to do was really have a much larger budget, and then was to really have a funding strategy where you're funding clinics all around the city that are no barrier, so you start to have something like a system that people can get connected to. One of the things we knew back in 2019, it's actually from polling and surveying that we did, I think it was in 2016, one of the most common things that residents said was that they didn't get connected to mental health services they needed because they didn't know where to go to get them, right? So we historically have not made it easy, where we had one phone number, one website. So that's what we've been trying to solve for here, that you can call 211 and say that you need mental health services, say what type of services you need, the community you live in, and 211 can connect you to that. The other thing is you can go to our website at mentalhealth.chicago.gov. So our team runs all the data that are in this resource finder, and any no barrier clinic that we fund will show up in this resource finder. We're adding a bunch of new sites probably in the next 2 months or so. You'll start seeing it, and we're making other updates to this resource finder, new languages. I think we'll have it in Mandarin and Arabic and Polish soon, and we're making a number of other changes. We're even interested in this idea of folks maybe being able to schedule appointments or communicate with the chatbot to say what you need, and maybe the chatbot can give you some instructions if you don't want to talk to a person over the phone. So one of the things we're really excited about is our partnership with Chicago Public Libraries. One of the things we've really been working on, Dr. Arwady, and I know you and I have talked a lot about it, is getting out of our departmental silos. It's really exploring partnerships with other departments around the city. And so last year we launched a partnership between the health department and Chicago Public Libraries to expand access to Narcan, which is the medication that reduces an opioid overdose. We now have Narcan available in all 81 libraries around the city. We've trained over 300 library staff. In about a year, we've distributed over 4,000 kits of Narcan citywide. We love libraries for lots of different reasons. I'm a book lover, and I know many other people are too. So libraries are safe and respected places to get connected to lots of things, not just books. But the network also has great geographic reach. And so it's a great way for us to make this medication available in every single community. in a non-stigmatizing setting where you could be going into that setting to get any number of things. And we really have had a lot of success with this. So we've started to engage in a conversation about what would it look like to embed health departmental mental health clinicians into CPL locations. So we're starting, we started 3 weeks ago, a new program which is what we're calling the city extension clinics. These are settings where clinicians on our team at the health department actually provide mental health services in a piloted set of libraries around the city. So you see the 4 branches we're in right now. We selected these locations because these are locations where we didn't have city-funded mental health services or city-funded mental health, city-operated mental health services in these communities. And part of our All 77 strategy is to be in every single community. So we've started 4 of these so far. You can get counseling, case management, etc. We're going to explore being able to integrate telehealth in the long term where, for instance, if a person wants to get connected or assessed for a mental health medication, we're exploring being able to integrate telehealth services into these sites. Right now, if you want to get connected to these, you can call 211 or you can go and call our Lawndale Mental Health Clinic, which is our primary site that we have people call, and we'll drop that number in the chat box. We also are really excited to be starting another CARE team. CARE is our program that integrates mental health professionals into the 911 system. It started in the fall of 2021. Currently, we have teams. We have 4 different teams working around the city, and we're adding a 5th team this week. You see on this slide, we have what we call alternate response teams, which are a paramedic and a mental health clinician. We have a second model, which is called a multidisciplinary response team, which is, again, that paramedic and the clinician plus a CIT-trained police officer, which is an officer with specialized crisis training. And we actually have a third model, the opioid response team, which is a team of a paramedic and a peer recovery specialist, which is a person with lived experience of substance use disorder who's in recovery, working on the west side of the city. I'll tell you more about the team we're launching this week in a moment. So this shows you the data. You can go to our website. If you just Google it, we have a great CARE dashboard that shows all of our data across the communities that we're in. We're about to start adding our data from the opioid response team shortly. And the team that's starting in the loop this week, you will see their data start getting reflected on this website very soon. So you see, so far we've had 617 crises that we've responded to through 911, 518 follow-ups, no use of force, no arrests. And obviously the purpose of this program is to treat mental health and substance use crises as health events rather than as calls that are primarily dealt with by public safety. You see here the reach of the program around the city. So the darker blue color is the districts that we are in currently. That middle blue color is the opioid response team, which is currently up and running.
When did that launch?
The opioid response team launched in January. Mm-hmm. And then the yellow are the communities we're launching in between now and summer, and at some point during the summer. So you see the site down in the loop there is launching this week. So we will have an alternate response team, which is, again, a clinician and a paramedic that will be operating down in the loop. And our goal is really to continue to scale these programs. We chose these community areas based on call volume. So these are communities that have the highest number of mental health calls with to the 911 system. And so we prioritize those first. Our next goal is to add a second shift in these communities, which is something we'll hope to do by the end of the year. A lot of that's going to depend on our ability to hire and train up new clinicians who want to do this work. We also, I think what's really exciting, have approvals from the state, because our program is regulated by the Illinois Department of Public Health EMS Division, to start integrating these teams into calls that are traditionally handled by law enforcement because they are calls that relate to, for instance, things like suspicious person or trespassing. And these are calls that are, we know when they have a mental health component, our argument is that we think these teams are better positioned to address those calls. So that's where we are right now. The team's been really, really busy, but if you live in the Loop or you shop in the Loop, you'll start seeing those teams shortly here because they're starting this week.
All right, great. So lots of questions coming in already. And I'm just sort of doing a quick search through some of what's coming up here. So let's actually start, let's start with Shannon Heffernan on Facebook. Says, both mayoral candidates have promised to reopen the mental health clinics. You've laid out why you don't think this is the best use of city resources. If you stay on under their leadership, how will you respond to that promise? Have you been in touch with them about your and their plans? And I'm just going to start with a framing here a minute. So just for folks who may not be aware that always the commissioners of departments are appointed by the mayor. And so traditionally, most frequently, when there has been a change in mayoral administration, I'm going to be honest with you, the public health department tends to fly a little bit underneath the radar. And so we have often seen not a lot of change in leadership between mayoral administrations. I am well aware, and I'm glad that public health is now very much on people's minds because of COVID, because of mental health, because of all of these things. And so I just want to, because we're getting questions about this too, I just want to say, my intent is very much to stay on in this role, as I know yours is as well. It's possible that a new mayor could go in a different direction. I think regardless of what that decision looks like, though, we have done some pretty remarkable work over these last few years. And when we talk with partners, Matt and I were at a meeting this morning with a mental health provider that is doing some really interesting things in Chicago with people who are higher need, who have mental health needs beyond what can be treated in the outpatient system. These conversations about how do we continue to build systems level work, that for me is the bigger conversation for government. And so I'm going to let you sort of start with a little bit of the thinking there. And this is a big conversation. We could talk about it for a long time. I also want to talk about funding, but why don't you kind of start there?
I think, thank you for the question, Shannon. I think what's characterized our approach is investing in both city services and in our community partners. So when I started, for instance, we had 50 mental health staff at the health department. We have about 100 now, and they're doing different things. When I got here, the only thing our staff did was we were working in clinics. We now have teams that answer 911 calls. That's a huge program. The size of that program, when it's at scale, is going to be as big as the clinic program was before the clinic closures, right? We have a group of people that just manage and coordinate the city's mental health system. We long needed that, and we didn't have it. So I think it's a false choice when we see city-run services pitted against the broader system. The reality is, in the third largest city in the country, you have to invest in both. And it actually dates back to a kind of austerity mindset that has existed in this city, that we don't have enough money to fund the broader system and have strong city-run services, so we have to choose. You can't choose. And that's the advice that I would give any mayor, is that you have to invest in both. You have to invest in our partners, and you really have to get at scale citywide in a city of 3 million people. And that's why you see that with the Chicago Public Libraries partnership. That's why we're doing that. That's our clinicians. So certainly, whoever the next mayor is, if they have ideas about opening new sites, that's something that we would engage with them on. I think you've got to do it strategically, and you've got to think about how do you have a truly well-functioning citywide system. But I've always been open, and Dr. Arwady knows this, to expanding city services and investing in our partners. It's critical to the approach we take.
Yeah, and I would just, adding to that, it's not that we're against mental health clinics, of course. It's about thinking about how do we use the resources that we have. And I think a lot of folks maybe don't know all of the changes that have happened in the healthcare system and the way that safety net healthcare is funded over the last 30 years. If you go back to this conversation about, do cities operate clinics, et cetera, I think about things like in 1996, the huge federal work that was done to create a safety net system through federally qualified health centers, to actually pull together people who were doing safety net care and migrant care and care for people who are experiencing homelessness, and to say, we need to create a system in this country that makes sure people can get primary health services and mental health services, and we're going to fund that work. We're going to make sure that people can get extra funding to take care of people who are uninsured. Like there's a lot that goes around that. A standalone mental health clinic cannot be a federally qualified health center by definition, which means we can't access the funding that comes, the billions of dollars that go into this system around safety net at the federal level. Similarly, I think we have seen with the Affordable Care Act major changes in terms of making sure more people can access insurance, that becomes affordable, but that also we've seen the expansion of Medicaid. And so there's this work of making sure people, if they are able to get connected to insurances, that becomes part of it. It's not that I don't want to open mental health clinics. It's that if I'm thinking about City of Chicago taxpayer dollars for mental health, I want to make really sure that those dollars are filling in the spaces that come with the huge amount of mental health funding that the state puts in, that the county puts in, and that the federal government puts in. And there clearly are gaps, right? This is where our work has been to say, where do we put city taxpayer dollars to help people get mental health resources? And the work, for example, of saying, let's think about putting mental health clinicians into libraries, that's a recognition that we know from talking to people that there are a whole lot of folks who have the highest need for mental health who don't actually necessarily want to go to a standalone mental health center, and where we can and have been able to get mental health clinicians more available at sites that they're already going to, whether that's their primary care doc, whether that's a food pantry, whether that's a library, bringing services outside of the walls of clinics. The people who most need mental health resources in this city, frankly, are often not the people who are going to keep a 10 a.m. appointment on a Tuesday at an outpatient mental health clinic. So we've really leaned into what is the appropriate need for the city. I think, the city operates 911. So I feel really strongly about making sure that we don't have somebody else out there operating 911. We've got to do that really well and get mental health resources in and think about crisis and do that. There are hundreds and hundreds and hundreds of people publicly funded by the federal government, the state government, the county government, and the city government. And we're working to create a network for all of those. So I don't think it's this either or.
No, and I think the bottom line is, as a clinical social worker, as somebody who has mental illness in my family, anybody who wants to do more on mental health is somebody I want to talk to.
That's exactly right.
It's not an either or proposition. There's a lot more to do, lots of opportunities for creativity, and so welcome those conversations as we move forward.
I've been pleased, I know you have too, to see how much conversation there's been around this with this election, we love Focus on Mental Health because the investment in that area is what this city needs. And I absolutely, am glad to see that level of interest and commitment. And it's not that we're against mental health clinics, but it's about just making sure that where we are using resources, we are using them in the way that, as a public health department, serves the most people with high quality services and no barrier to care. And maybe the last thing on this, just because there's lots of comments and questions, I think of it as a corollary to immunizations, actually. Immunizations is key work, of course, that the health department does every day. There are millions of vaccinations that get administered, and the health department does not put the needle into every person's arm there. We help fund and distribute vaccination. We do a lot of quality control. We do a lot of connection and funding to hundreds and hundreds and hundreds, especially of safety net providers, pediatricians' offices, family practice offices, federally qualified health centers. We also then layer on health department resources where we see gaps in that system. So like our Protect Chicago at Home program, that's brand new work of saying, we know that there are people who just have trouble keeping an appointment, aren't able to get it. It's not about doing do I open up another immunization clinic? We have some of those. It's about saying, how do I get more creative with bringing those resources to where people are? And really, that's how I think about most of our public health work. It's not that we don't do work, it's that we say where are gaps in the current system and how do we creatively help meet the needs of people who otherwise aren't going to get the services that we need. And I think, I strongly believe that everybody in this city should be able to access vaccination regardless of their insurance, their immigration, and their income status. And I feel the same way about mental health. Okay. So that was a lot, but there's been a lot of questions there. Okay, so Lauren Renfro on Facebook is asking, why would you put CDPH workers in libraries providing mental health services when you could reopen a clinic? When you could place social workers in libraries to provide connections to resources like housing and resume building and job training, et cetera. Anna, similarly, why did you decide to place extension clinics in libraries? So maybe a little more about that conversation.
So part of it is, what's really most needed is access to more high quality treatment in underserved communities. So what we know is that in underserved communities, there's a much lower number of providers that provide high quality mental health services at no cost. So it's really about how do you get access to the provider, number one, less than it's about how many buildings do you open. The second thing is not everybody wants to go and get services in a standalone mental health clinic. So one of the things that we have done is how do you start integrating mental health professionals across a wide range of settings, right? Whether you're talking about libraries, whether you're talking about schools, whether you're talking about airports, primary care clinics, shelters that serve unhoused people. We have a history in this country with mental health of siloing it off from the rest of other systems. It's off on its own, and the history of stigma travels with it. That's why there is a lot of mental health stigma, is because we have not integrated mental health into the institutions that support our daily lives. In my opinion, that's been a significant strategic miscalculation, and one we're trying to now correct for. That clinicians are in a wide range of settings that people use in their day-to-day lives. So that's the primary reason we're pursuing that strategy. And we also have identified airports as an opportunity, starting with an intended pilot mental health program that, again, our team at the health department will staff at O'Hare Airport, both on land side and air side.
All right, good. So let me hit a few of these quickly. So Ina G from Facebook says, a lot of these nonprofit mental health centers have 6-month wait lists, which we'll talk about. She says there are barriers. How frequently does CDPH audit to check wait list times? Can you talk a little bit about that wait list work?
Yeah, so we have, thank you for the question. So we do look at wait lists. I think something where we would like to do actually with the resource finder is actually start mapping the data related to wait lists. So what I'm envisioning, and again, we have to work with our IT gurus, which is not me, something I did not learn in social work school, is how can we, for instance, visualize on the map if there's no wait list, or if there is a wait list, and if there is a wait list, how long is it? Dr. Arvedi, you might want to talk about mapping wait lists, the work you did in 2016, which I think showed some interesting things that we need to...
Yeah, for me, when I came over to the health department, I was initially in the chief medical officer role. So I was working across the health department with a lot of primary focus on infectious diseases, but also, especially as we started to see fentanyl come and these huge increase in substance use and mental health needs, got really interested. And for me, the most important piece of data and visual that made me kind of change my thinking a little bit on where the needs were and what we should be especially focused on as a health department was this work from 2016, where we asked in a whole lot of detail anybody who was serving sort of safety net mental health needs. The city wasn't funding them. It had nothing to do with funding. What are your wait lists? What are your wait lists for different services? How long if somebody's calling and they need to get psychiatry versus therapy versus family therapy? What if it's a child? And I can't even express to you how shocking these maps were. It's not just that we were seeing, in some cases, very long wait lists. It's that sometimes you would see two clinics blocks apart from each other. And one clinic would say, it's taking me 6 months or 9 months or 11 months to get somebody into psychiatry care, but I can see someone for therapy tomorrow. And 6 blocks away, we've got someone saying, I've got a psychiatrist. I can see you for psychiatry, meaning medication needs, within a couple of days. But man, I don't have therapists. And my people who need to pair that psychiatry with therapy, they're waiting months. And it was this real, for me, like visual understanding that we've not done the work. That's not how our mental health system is built up. It's all been sort of done at an individual level. There hadn't been that work to really look systemically. And so much of the work of the trauma-informed centers of care is to say, no matter where I'm getting this piece of my therapy, is there somebody right next door who can connect on those other pieces? I want people to be able to get high quality care near where they live. And I don't want, and I want to make sure that we're using resources that are available.
And that's an appropriate thing for government to do, because we know the healthcare system doesn't typically think about the coordination of the broader healthcare system. That's something really government can do. So if we're able to centralize waitlist data so that people, when they're looking for services, or providers when they're making referrals, I think that would be a significant value add to the system in the city. And it gets back to residents telling us it's hard to get connected to what I need.
Yep. Still mostly mental health questions. I see a couple of these other COVID, which I'll get to in a minute, but let's keep going on here.
Sure.
Megan is asking, how do you know that you have the most up-to-date info on the resource finder? I've used resource directories before. The info isn't always kept up to date.
Yeah, thank you.
It's a good question.
So we actually made a decision, Megan, to bring the resource directory in-house at the health department. So our, I mentioned before, we've doubled the size of our mental health team from 50 to 100 people. One of the teams just does system coordination, so they manage the resource directory. And part of what they do is that they update it every 3 months. So they add new sites, and then we have a mechanism also for sites to tell us if there's a change. Are they adding a new service? Are their hours of operation changing? We also proactively require that you update us. So it's a condition of funding from the city that if we fund you to provide mental health services, you have to provide up-to-date data. So we've brought that in-house so that the city of Chicago is now managing that data set, because exactly to your point, these things can change quickly, and we don't want people getting linked to sites based on bad data or outdated data.
All right. Just for time, let me take a couple of non-behavioral health questions, and then we'll come back and get a few of the rest of these. Alexandria Dion on Facebook is asking, seeing a bunch of news reports lately on the rise of the Candida auris fungal infections. Do you have any information on that, and are we seeing it in the Chicago area? So yes, we have a lot of information on this. In part, so for those who may not know, Candida auris is a fungus. It can be really serious, especially in people who are immunocompromised, on ventilators, really ill in hospitals, and we can see some spread in healthcare settings, which can put other people at risk. And when Candida auris was really identified as a significant healthcare threat, it actually was in New York and in Illinois where we first had some of the detection in place and some of the work to very intensively work in our high-risk settings to limit that spread, make sure it's being recognized and treated. And so just on a personal level, before I was at the Chicago Department of Public Health, I was working for the CDC, but assigned to the Illinois Department of Public Health, so this is probably a decade ago. I spent a lot of time working on Candida auris, working with local health departments, with long-term care facilities, with academic researchers, and we have a team at the health department, as you know, that is very, very focused on these higher risk settings, long-term care facilities especially, settings that have ventilators, the machines that people use to breathe. If people are on those for months or years at a time, that's a really high risk setting. And there's been a couple of news pieces on this recently. One is that we have seen significant expansion of this fungus across the U.S. So during COVID, where there was a lot of stress on the healthcare system. There may have been some more reuse of personal protective equipment early on where those supply chains were disrupted. We've seen a lot of other things take priority. Not surprisingly, the spread of these organisms that can be very hard to treat or are drug resistant or can spread in healthcare, we've seen some more of that. And so now many, many more states are seeing Candida auris. But reported on a little bit less, and important for you to know, and work that I'm really proud of, is that in Illinois, where we had it early, even during COVID, we've actually had very good success in containing, in not seeing significantly more spread. That work that started, more than a decade ago here, of making sure that whenever a patient comes into an emergency department, is admitted to a hospital, behind the scenes, we have some work that is able to quickly compare that list of individuals who are coming in to a list that is kept centrally of people who have a history of these kinds of organisms that can be really problematic in the healthcare setting. If somebody is identified, we work really quickly as a system to make sure that the protective equipment and other things are in place. Obviously, there's full protection of privacy there, but the good news is that while there's been a lot of focus on Candida auris, and there should be, it's a real concern, we are known here in Chicago and Illinois as being one of the places that detected it early, has put a lot of resources into controlling it, and even during COVID have managed to keep it under reasonably good control from a spread perspective. So thanks for that. And maybe at some point when we have our long-term care folks and my healthcare associated infections team, it's one of our best teams at the health department, we'll have them back on at some point, and would be more than happy to talk in detail about all things Candida auris. And then just the other question I wanted to take on infectious diseases. Sure. Face State on Facebook says, will people who want a second Omicron booster be able to get it? For many people, it's already been over half a year since they got the first booster. Yeah, thanks for that question, Faye. I get versions of this question a lot. At this point, there is no recommendation, as you know, for another booster. This is different than what we were doing in the first year or two as vaccines came out. We were seeing a lot of change in COVID itself, right? The Alpha variant, the Beta, the Delta, and then Omicron especially. And as the virus is changing really quickly, it is a big challenge to try to keep up on the vaccine side and on the treatment side. But over the last year and a half, thankfully, we've seen some stabilization on the virus side. Continued mutations for sure. That's what these subvariants are. But the updated vaccine that became available last fall was designed to protect against Omicron, to protect against sort of the changes that we've seen in the virus. And unless we see another major unexpected change quite soon here in COVID, that remains the most important thing that you need to do. So, I always say with COVID, anything could change, right? And that's why we have these systems in place to really make sure we're monitoring and making sure we're prepared. But there is no recommendation. And at this point, I'm not seeing anything suggesting that there would be another recommendation for people to get another booster until most likely this fall. My guess is that this fall, similar to what we do for flu, every year we look at the strains of flu and we make a flu vaccine that people take ideally every year to help protect them through the next winter. My guess is that's where we're heading for COVID. And so if you are up to date, you got your Omicron booster, your bivalent booster in September, October, November, December, January, February, March, you're up to date. And at this point, no recommendation for another one. Do trust your vaccine. The belt and suspenders approach is to be able to take an early treatment if you do get COVID, on top of being up to date with your vaccines. So good questions there. All right, just in the last couple of minutes, let me do a time check. We've got just a few minutes left. So there are some folks putting in lots of comments and questions here. So maybe a few things about the libraries. Lauren Renfro is asking a whole host of questions about the libraries. So let me just give you a sense of some of them. She says, can you explain how you see this as the best use of resources? I'm confused to the reasoning. Are the clinicians public employees or contractors? And then finally, how are we raising awareness about these programs?
Yeah, so the public library partnership is staffed by clinicians at the health department. So they're employees of the city of Chicago, right? And so the idea, again, around extension clinics is what you are doing is you're focusing on creating access points to high quality mental health services in the community in physical settings that already exist. The city of Chicago has buildings all around the city of Chicago. We have libraries, we have parks, we have schools, we have DFSS service centers. From my vantage point, it makes absolutely no sense that you would spend lots of money building yet another building when you have lots of other buildings in the community that are already a part of people's everyday lives, right? Not everybody wants to go to a standalone mental health clinic. So if you can create access to mental health services in a school, in a library, in a parks program, in a food pantry, right? That's part of what this is starting to really increase access to high quality mental health services in lots of settings, not just standalone mental health centers. Now, does that mean I'm saying I don't think there's any argument to open more mental health centers? No, I'm not saying that. I don't think that's incompatible necessarily with the approach. But I would strongly argue that you need to be integrating mental health professionals into a much wider array of settings, which is what we've done. So you have it in primary care, you have it in libraries, you have it in schools. We're looking at doing the same thing in the airport. So it's an attempt to really start to integrate mental health into a lot of settings that we interact with in our everyday lives. And yes, the extension clinic program is staffed by our team members at the health department.
Yeah, and maybe, on this is new. We've not tried this before. We'll see how it goes. But it's been really, really good to work with Chicago Public Libraries on the substance use side, on the Narcan, on the training. They've been really excellent partners. And they said, you know what? We have a lot of people who come into our libraries who could use mental health resources. And it was this combination of where are we wanting to fill some gaps, but also where are there libraries who said, we're really interested in being a resource in this way also? Because right now, there are people using our libraries who have need for a service that we're not able to offer. So it's new, we're gonna see how it goes. The question of sort of what are we doing to lift it up? I think one of the things is talking about it on things like Facebook Live, just like we did for Narcan, series of trainings for the library side, thinking about signage, thinking about drop-in versus appointments. But I feel really strongly about making sure we are getting mental health resources to people who are already accessing public services.
Yep, that's right. That's a good way to put it.
And trying to be creative about what we're doing with that. So I'm glad you're interested. Meredith is asking, how do other big cities do this? How do other big cities approach ensuring the access to mental health services to all residents? Are there other places doing similar work?
That's a great
I love this question.
So that's a great question. So one of the things about the way, and you may know this, Meredith, you said?
Meredith.
You may know this, Meredith, that mental health is very largely federal money for mental health travels through states. So a lot of the time, actually, cities don't really get any mental health funding unless it's allocated in the city budget. And historically, our city mental health budget has been very, very small. Going back to 2019, it was $12 million, which was basically enough for us to operate our 5 clinics and then have a very small grant program that was like $1 million a year. Now that we have a budget that's including ARP funding, it's about $90 million. We can do a lot more with that, which has allowed us to expand substantially our city mental health workforce. I mentioned it's doubled. Really start to actually fund other safety net settings, no barrier mental health providers around the city. Do things like have a website, have one number you call, have a mental health marketing campaign. So we actually right now are doing an evaluation of looking at after, in the wake of COVID, how are other big cities handling mental health and how do our strategies compare to it? My sense of it is we are frankly doing a lot more than most cities are. Most cities do tend to depend more on the state because states control Medicaid, all the federal money travels through the state. I don't think we absolutely have to, as Dr. already said earlier, integrate or coordinate our strategies with the county and the state and the federal government. But I'm a strong proponent of the belief that the city itself needs to have a robust mental health budget. We need to have a mental health staff. We need to have our own direct services, like our 911 program, like our own clinics, and we have to fund other providers. You have to do all of that in a city that has almost 3 million people. And I think there's tons more to do, don't get me wrong, but I think if you compare the direction we're headed in, it's quite different than the city's history, which has been having a small mental health budget, having some of its own clinics, and that was really the scope of what we did.
Yeah, and as the public health department, it actually is our job to think about large numbers, to think about how do we make sure our immunization numbers are in the millions, more than 5 million COVID immunizations to City of Chicago residents. Same thing on mental health, frankly. Like, I was not satisfied with a strategy where we were serving 3,600 residents. And even if you go back historically, when we were operating more clinics, this is before either of our time, but let's say if you're serving 3,600 residents across 5 clinics, plus a little bit of the other pieces, if you double that number of clinics, if you triple that number of clinics, you're going to serve more patients. That's critical. But you're going to go from 3,000 patients to 6,000 patients to 9,000 patients. Essential work. We've got to make sure those 9,000 patients get served. But 9,000 patients in a city of almost 3 million people and a lot of folks who are falling through the cracks, it's not thinking big enough. And so it's not that, again, there's been this interesting sort of dichotomy between do you open clinics or do you make sure people can access clinical services? And they really go together for me. What I don't want to see us do, we're not opposed to mental health clinics, to be clear. We're not opposed to opening mental health clinics, especially if they're in spaces where the data suggests there are gaps and needs. But what I want to make sure we do is think in the tens of thousands or hundreds of thousands where we're talking about the number of people served. And so, when I go back...
It needs to be hundreds.
It needs to be hundreds, right. We're up to 74,000. That is amazing compared to 3,600. But think about the need that's here and what needs to grow. And, when we were looking at this 4 years ago and saying, what is our strategy going to be? We did some calculations and we said, yep, we think if let's say we reopen these clinics and we use the amount of funding that would take just, and the staffing and doing all that, we would double the number of patients that we were seeing. 6,000 patients, it's not enough. We set a goal of 60,000 a year, and we beat that, actually. I was very pleased to have hit 74,000 people, and we're not there yet, but I worry a little bit that the conversation here, I'm thrilled that everybody is excited about mental health and wanting more resources. And we love opening clinics. We want to open an STI clinic. Like, it's not about that. It's about thinking big enough. And anybody who thinks that any city anywhere in the world on its own is going to stand up direct clinics, you're not thinking at the scale that public health really, needs to think at. So it's not an either or, it's a both and that really has been our approach.
That's right.
Okay, so I think we are just about at time here. So for folks who are curious, if you go to our website, there's people who want to know how could they get Narcan.
Oh, great, good.
There's good information on the website. We've got an email and a phone number. We are more than happy, especially if you work in a clinical setting, we'd love to get Narcan out to you. So we'll follow up there, reach out to us, and there's easy information on the website to find there. And yes, we do training around Narcan also.
Can I say about Narcan? So there's Narcan at every single library, so you can go to your local library, but you can also call us or email us, and we'll put it in the chat. We will send you Narcan or fentanyl test strips as well. Fentanyl test strips is something we're starting to add into the library program, so that allows a person to test a drug for the presence of fentanyl, which is a very powerful opioid that is frequently connected to overdoses.
And Jackson specifically is saying, Jackson works at a nonprofit.
Yeah.
Would love to have Narcan available in our building and training for our staff.
Yeah, please contact us. And Megan, if you could just put my email in the chat too. You can just email me, Jackson, and we'll get you signed up. So we provide free Narcan, free fentanyl test strips to literally hundreds of organizations around the city. So very happy to add you all to the list. Thank you for doing that.
Yeah, and nonprofits that are thinking about integrating substance use and integrating mental health access into whatever work you are doing, thank you for that. And we would love to continue to partner and get you the resources that you need. So thank you for that really concrete ask. Okay, we are out of time. So thank you as always for your thoughtful questions and your engagement. And we are not doing a Facebook Live this coming week, but we will be back the following Tuesday, April 4th. April 4th, we have a focus on STIs, sexually transmitted infections. Dr. Irina Tabitze, who works at the health department, does a lot in our what we call our syndemic infectious disease unit, which looks at HIV and sexually transmitted infections and hepatitis and tuberculosis, and thinks again about how do we systemically approach these issues. It's another area where the health department delivers some direct services. We operate some sexually transmitted infection clinics, and then we do a lot of coordination and really trying to think at a systems level of how do we make sure anybody who needs testing or treatment for STIs gets connected. And we've seen some changes there during COVID too, and some concerning increases. And there's a lot that's happening in that space. So anyway, Irina Tabitze will be our guest on April 4th. So thank you all very much for your time and your questions. We'll see you in a couple of weeks. Bye-bye.
Thanks. Take care. Bye-bye.